In this video we shall learn about laparoscopic caesarean scar pregnancy, CSP. We are about to see the laparoscopic management of a caesarean scar pregnancy, one of the rare but serious variants of ectopic gestation. Caesarean scar pregnancy by definition is implantation of the gestational sac within a previous caesarean section scar. The increasing incidence caesarean scar pregnancy parallel to rise in caesarean deliveries. Asterisk accounts for approximately 6% of ectopic pregnancies. Caesarean scar pregnancy may be asymptomatic in some cases and may present with shock. Transvaginal ultrasound is the gold standard in diagnosis. Complications includes massive hemorrhage, uterine rupture and placenta accreta spectrum disorders. Management can be by medical or surgical depending on the grade of caesarean scar pregnancy. This patient is 33-year-old female, gravida 3, para 2, living 2 with previous 2 lower segment caesarean sections. In the second pregnancy she underwent LSCS at 33 weeks for placenta previa with antepartum hemorrhage. Now we shall see the video demonstration of laparoscopic repair of caesarean scar pregnancy. Step 1. Here, we have the laparoscopic view of the pelvis. The uterus and adnexy look normal, but notice this additional bulge at the level of the previous caesarean section scar. This is the scar pregnancy, sitting just above the bladder. Always take time to orient yourself and identify the bladder before proceeding further. Step 2. We inject diluted vasopressin into the myometrium. This helps minimize bleeding, which can otherwise be torrential in these cases. Remember, slow and controlled injection is crucial, and avoid direct intravascular spread. Step 3. The bladder is carefully dissected off the lower uterine segment. Patience here is key. The pregnancy tissue is often densely adhered. Notice how the dissection stays close to the uterine wall, keeping the bladder safe. Alongside, the uterine vessels are identified, giving us the option of securing them quickly in case bleeding becomes difficult to control. Step 4. The dissection is carried down until the anterior cervix is visible. This step gives us a safe workspace to excise the scar without risk to the bladder. Step 5. Now the scar tissue is opened at the junction with healthy myometrium. Once opened, you can see the products of conception within the defect. These are gently aspirated. Notice the importance of distinguishing where normal uterine wall ends and scar tissue begins. This prevents removal of unnecessary healthy muscle. Step 6. To ensure proper orientation of the cavity, a cervical dilator is passed from the cervix into the uterine cavity through the scar tract. This helps in two ways. It confirms continuity with the cavity, and it prevents accidental narrowing while suturing. This is a useful tip to keep in mind for future cases. Step 7. Closure is now performed with a barbed PDS V-lock suture. Notice the technique. Suturing starts at the right corner and proceeds across without tightening after each bite. This way, visibility of tissue edges is maintained. Once the opposite corner is reached, the suture is sequentially tightened, bringing the defect edges neatly together. This creates a strong, watertight closure of the lower segment. Step 8. Finally, the bladder peritoneum is closed over the repair. This step restores anatomy and provides an extra protective layer between the bladder and the suture line.